Good evening, everyone. I'm Dr. Sheldon Goldberg, and I'm CVI's president and one of the directors for CVI's Fellows in Interventional Cardiology Committee. Welcome to this evening's program, Stroke Prevention, What All Frontline Healthcare Workers Need to Know. Before we move into this evening's program, I'd like to thank CVI's Fellows and Interventional Cardiology Planning Committee, which represents all of the major academic centers in the Delaware Valley. And we've even included the swing state of Florida by Dr. Ellen Keeley. Also, we'd like to thank both Janssen Pharmaceutical Company and Boston Scientific for their generous educational grants that have helped to make this program possible. In addition, we'd like to thank our generous exhibitors and sponsors who've helped to make this program possible as well. Thank you to our leader level exhibitors, Abbott Laboratories, and Pfizer Bristol Myers Squibb's partnership, as well as our supporter level exhibitors listed here. It's my privilege to introduce our keynote speaker of tonight, Dr. Jeff Saver, who's professor of neurology at UCLA and director of the UCLA Comprehensive Stroke and Vascular Neurology Program. He's served as the principal investigator of pivotal national trials and is chairman of the American Heart Association Stroke Council. He's currently associate editor at JAMA and the Journal of the American Medical Association and consulting editor at the journal Stroke. Jeff, thanks for doing this and welcome, and we look forward to your presentation.
Thank you so much, Shelley, and it is an honor to be invited. And as a native son of the Northeast, I am so pleased to be traveling virtually back to be with you today and talk about this topic of cardioembolic stroke, which is a burgeoning and dynamic space of knowledge advance, and share that with you today. Here are my disclosures, and in the course of the talk today, I'll be covering the epidemiology of stroke overall and cardioembolic stroke in particular, and then talking the approach to the diagnosis of different manifestations of cardioembolic stroke and sources, handing everyone off after that to our cardiology speakers who will talk about the treatment that results from a neurologic diagnosis. I'll talk broadly about general approach to stroke diagnosis and then about two specific hot topics in cardioembolic stroke diagnosis: occult low burden atrial fibrillation and PFO associated stroke. So beginning with epidemiology, as everyone knows, stroke is very commonly first leading cause of serious disability and second leading cause of death worldwide. And here in the US, again, leading cause of disability, now the fifth leading cause of death, second leading cause of dementia, greater burden in African Americans and Hispanics. 10 years ago, stroke was the third leading cause of death. We have made progress in prevention at the age-adjusted incidence level, but because the population is aging to the stroke-prone years, we're still having more strokes every year. And this year, stroke will be the sixth leading cause of death due to COVID, but we hope that will resume being the fifth leading cause of death thereafter. When you think about the causes of stroke, which is of course a very heterogeneous disease, broadly there are the ischemic strokes due to blockages in blood vessels that account for 80 to 85% of strokes in the US, and the hemorrhagic strokes due to rupture of blood vessels and bleeding in the brain or subarachnoid space that account for 15 to 20% of strokes. And among the ischemic strokes, the three most common causes are large artery atherothrombotic disease, cardioembolic source, then small vessel disease. About 10% of strokes have other defined causes. There are 100 or more additional causes, each accounting for some. And then still, even in the modern era, 20% of strokes we don't find the cause for and are cryptogenic. If we look at down on the cardioembolic category broadly, the major cardioembolic sources are number one, atrial fibrillation, the source of half of all cardioembolic strokes. Number two, we have ischemic ventricular disease, both post-MI in the first month and then long-term LV aneurysms with thrombi in the LV thrombus. Then we have valvular disease, native valve disease, including rheumatic AF and prosthetic valves. And then we have a grab bag of other causes, patent foramen ovale, endocarditis, atrial septal defects, and other causes. Those, as at a broad level, at the detail level, as the cardiologists in the audience know much better than I, there are many individual cardiac diagnoses that roll up into these broad categories, and some not completely covered about them. That is part of our workup for cardioembolic stroke. Well, what does that workup consist of? How does a neurologist approach these patients in order to find out which patients have cardioembolic stroke and should be referred for different cardiac interventions? The diagnostic assessment that the neurologist goes through is to characterize the clinical presentation, the who, what, where, and when features of how the patient came in. The stroke topography, what is the territory in the brain that the stroke occurred? Where did emboli or land, and what does that say about their source? And then to look at all the arteries from heart to head, look for structural disease of the heart, look for dysrhythmias, and look at hematologic disorders, disorders of the blood. If we consider the presenting clinical features of the major ischemic stroke subtypes, large artery, athero, cardioembolic, and small vessel, the distinctive aspects of cardioembolic are it's maximal at onset. 80 to 90% of patients, sudden maximal deficit. They don't progress. The thrombus lands in the brain and causes the maximal onset. Uncommon TIAs proceeding, unlike with atherosclerotic disease, only 10% of patients will have had TIAs, and when they occur, they often are in different territories than the current stroke. And typically, it'll be a large artery recipient syndrome with cortical signs commonly being present. Once we have the patient in hand with that presentation, we then go through different rounds of investigation, looking at these 5 major domains of cardiac structure and rhythm and heart and blood vessels and blood, with standard evaluation during the initial hospitalization. Often that will yield the diagnosis. If not, then advanced evaluation with more very specialized tests. And if that's still unrevealing, sometimes very detailed third wave evaluation. The patterns we look for in the brain are shown here. Typically, a cardioembolic stroke will have one of these 4 patterns: multiple emboli in multiple territories, classically, but also single strokes that are superficial, either large and deep or just superficial and small. And also large deep strokes, too big for single penetrators that reflect blockage of multiple penetrators in a parent artery. Atypical for cardioembolic stroke are small lacunes that are in the distribution of a tiny penetrating vessels. Emboli tend not to make right-hand turns. They go with the flow to the top of the brain into small arteries. And also unilateral border zone infarcts. These suggest a severe internal carotid disease rather than cardioembolism. We will, in the initial day or two in the hospital, often with the initial MR or CT imaging within the first hour of arrival, look at all of the vessels from aortic arch through takeoff of the great vessels, the cervical vessels, and the intracranial vessels, looking for atherosclerosis and other arteriopathies using CTA, MRA, most often ultrasound. PCD with embolus detection can especially be sometimes helpful with a unique way of looking at things. And then in uncommon and unusual cases, catheter angiography. The cardiac evaluation includes echocardiography, most commonly still for structural analyses, but increasingly fast-gated MRI and CT, and cardiac rhythm evaluation, both inpatient cardiac telemetry for a few days, and then increasingly prolonged outpatient monitoring. How should we think about, how do neurologists think about ordering these cardiac diagnostic tests in the stroke patient? One issue is when do you get a transthoracic echo and when a transesophageal echo? And in general, transthoracic echo explores the ventricles and ventricular septum better, and transesophageal, the atrium, the atrial septum, and aorta better. So if you suspect ventricular disease, if there's a history of MI or congestive heart failure, you want to begin with a transthoracic echo. If there's no history of MI or heart failure, very little yield in the cardioembolic workup with transthoracic echo, and you can often go straight to transesophageal echo to explore these sources. And if you look at all the high risk and medium risk sources that are structurally in the heart, you can see that they do break down to having a variety better discovered in yellow on transthoracic echo because they're ventricular, and others better discovered on red because they're transesophageal. And I think the best way to think about it is do the transthoracic echo first if there's evidence of past MI or heart failure or LV disease by exam. Also, just do a transthoracic echo if it's a single penetrator lacume, low likelihood of cardioembolic mechanism. Do transesophageal echo first if neither of these is present, because the yield of this will be very low, and do transesophageal second if you've done the transthoracic echo and it was unrevealing other than for lacunar stroke. All right, let's turn now to the two specialized topics of interest. First, discovering atrial fibrillation. We usually find AFib because the patient have it by history 15% of the time, because it's present for the first time known in their lives on arrival with their stroke 8%, or we find it during the inpatient stay 5% of the time manifest AFib. But in patients who have no other source of stroke, if you do prolonged monitoring for months, then 1 in 6 patients will be found to have low burden, infrequent atrial fibrillation. And predictors of finding low burden atrial fibrillation are having older age and having left atrial cardiopathy, a dilated left atrium, and other signs of an abnormal atria that will go into fibrillation. It's age-related strongly. Over age 60, you will often find occult AFib. Under age 50, not very often at all with prolonged monitoring. And we have a variety of monitoring available. Most recently, we have patch monitors that can go for 2 to 4 weeks easily, and the iWatch, which is now lifelong non-invasive monitoring, and subcutaneous monitoring for 1 to 3 years. The Apple Watch is now FDA approved, and I'm increasingly using it to supplement MedLink and ambulatory monitoring devices in my patients. There's a provisional algorithm for the diagnostic approach that is in the New England Journal of Medicine review from a couple of years ago that gives a flexible approach for when to get short-term monitoring and longer-term monitoring depending on your clinical suspicion that there's likely a low-burden AFib source. With regard to PFO, AFib, as we said, paroxysmal AFib will only be 1 in 6 of the otherwise cryptogenic strokes. So something else is going on much of the time, and often it's PFO. 1/4 of all people have PFO. That doesn't close after birth, as it does in most people in the first 3 months. And sometimes we know for sure when we see thrombus wriggling across the PFO and a patient has just had a stroke that that's the culprit. But more often, we have to say we found a PFO, but many people have a PFO, and is it true, and unrelated, or is it causally related? And we know from the clinical studies that when you have a cryptogenic stroke, patients much more often have a PFO than in the general population. And if you just crunch the numbers about how much more often it's found in patients with otherwise cryptogenic stroke using Bayes' theorem, you get that 1 in 6 of all strokes over age 55 that are cryptogenic are also due to PFO. And when you find the PFO, it's very likely the culprit. Under age 55, if you find the PFO in a cryptogenic patient, 3/4 of the time the PFO was causal. And over 55, more than half the time. And that's just doing math before we get down to clinical characteristics of the patient presentation and the cardiac structure. So this is a very common cause as we're increasingly recognizing 10% of all young and middle-aged strokes and 5% of all strokes appear due to PFO. We use the rope score to identify patients more likely to have a causal, in whom a PFO is found, more likely to be causally related. The rope score looks at atherosclerotic risk factors and age, and if you don't have those, don't have subtle atherosclerosis, then you're more likely to have a PFO. The higher the rope score, the greater the PFO attributable fraction. We look at the heart, atrial septal aneurysms, much more dramatic benefit from PFO closure because they potentiate the PFO and increase the likelihood that that present PFO was the actual cause of the stroke. Large shunts. The more blood you have going across the PFO, the more likely a venous clot is to take a turn across the atrium, skip filtration in the lung, and land in the brain. Also an important predictor of benefit from closure. And finally, embolic stroke topography. We want to look on history for whether there was long travel before the onset of the stroke, presence of a DVT or P, venous disease, and Valsalva at onset, migraine, because PFOs are also associated with migraine. They might be minor emboli provoking migraine, and wake-up strokes, because sleep apnea will cause increased right to left shunting and increase the risk of stroke. Air travel. Fortunately, I'm being spared this risk because we're doing this virtually, but nice large airport-based series have suggested that 1 in 5 strokes that occur during air travel are due to PFO-related paradoxical embolism in the air. Be sure when you take the history to find out what seat the patient sat in. If it's near the window, worry about PFOs on the aisle, a little bit less risky. Presence of a hypercoagulable state that causes venous disease and clots to form will also increase the risk. And we can look not only with lower extremity tests, but also look for pelvic clots with both MR and CT phonography. Most recent development, we have new nomenclature for PFO in stroke, because we now no longer would say these are cryptogenic when we have good evidence that the PFO was causal. And an international consensus group published this recommendation 3 months ago, that in patients presenting with superficial large, deep, or retinal infarcts in the presence of medium to high risk PFOs and no other cause, they should be called PFO-associated stroke. There is a strong indication of a causal relation. And we published in that paper an algorithm for assigning causality that takes into account the nature of the coexisting cardiac structures and the rope score to classify the probability that a PFO is causally related that you can flexibly use in clinical practice. So we have come a long way in the relationship between neurology and cardiology and the management of patients. We used to arm wrestle with each other, but driven by data and positive trials, we now are in a harmonious relationship in neurocardiology clinics where it's a great privilege to practice. Thanks very much for your attention.
Thank you, Dr. Saver, for a great talk on this very important topic. I would like to now introduce our next speaker. That is Dr. David Goldberg. Dr. Goldberg is Clinical Assistant Professor of Medicine at the University of Pennsylvania. David completed his fellowship recently. He aspires to contribute to the field of interventional cardiovascular medicine and cardiovascular education. He is well versed in many structural heart procedures, including Watchman implantations. He will be presenting a case on atrial fibrillation-related stroke in an older patient, anticoagulating therapy, and the role of left atrial appendage exclusion. David.
Okay, thank you very much. Seeing if I can control the screen here. Okay. So thanks again for this introduction. We have a lot to talk about in a short period of time. I'm going to start with a case here. She's a 77-year-old female with atrial fibrillation and recurrent GI bleeding. She has chronic diastolic heart failure, hypertension. She's obese and chronic iron deficiency anemia. Her first event of GI bleeding occurred in 2005 due to diverticulosis, which required a hemicolectomy. She had been on warfarin at the time. And then she did well for about 12 years or so and had another bleed in 2017 right at the anastomosis site from her previous surgery. It required a clip and an epi injection. She was on Pradaxa at that time. She lost a lot of blood, required blood transfusions, and was ultimately switched to Apixaban 5 milligrams. BID or CHADS-VAS was 5 or Hasbled was 4. So our therapeutic options here, one is to continue Apixaban and hope she goes another 12 years without bleeding. One is to reduce the dose in this obese patient to 2.5 milligrams BID. The next would be to stop anticoagulation altogether and go with aspirin therapy. And then, the most reasonable option here, obviously, would be to consider an alternative to anticoagulation. That would be the left atrial appendage closure. That's going to be our topic today, specifically with the Watchman device. We're going to talk about eligibility and indications for closure, with first talking a large amount of time on the data. And then we're going to talk about, the throughput of getting your patient in the office to the operating table, and ultimately when can you discontinue anticoagulation. So, we know about the CHADS-2 and the CHADS-VAS score. As the numbers increase, your risk of stroke goes up. But the CHADS-2 score wasn't really good at, they were good at identifying those patients with high risk, but not so good at identifying those patients with, low or intermediate risk, those that you could consider not treating with Coumadin. So hence the CHADS-VAS score. In Europe, they're a little bit more aggressive with anticoagulation, and anybody with the CHADS-VAS of 1, they're anticoagulating. So, with our CHADS-VAS of 2, how do we do in this country? You can see on the x-axis here, this is the CHADS-VAS score, and on the y-axis is the proportion of patients with atrial fibrillation receiving appropriate therapy. And these turquoise bars down here at the bottom is the histograms are that of those patients that are actually receiving warfarin. You can see as the CHADS-VAS goes up, the peak is at about 50% and then starts to drop off for various different reasons. Do we do any better with NOACs? Yeah, maybe a little bit, but the story's still the same here. At about 2 years, we're talking about 70% compliance. So there are a lot of patients that are left unprotected. And so that was the idea behind Watchman as an alternative to anticoagulation. It underwent heavy scrutiny. It started in about 2002 with some pilot studies. And then the first 2 trials that I'll talk about were 2 randomized controlled trials with similar design, a non-inferiority design that began in 2005 and 2010. And of course, you see the 3 FDA panel hearings until approval in 2015. This first PROTECT AF trial did achieve non-inferiority, but the real, as well as the PREVAIL, but the real issue was procedural related complications. And you can actually see that even within the first half of PROTECT AF, those numbers dropped significantly, and we'll talk about that. But ultimately, FDA saw this and said, hey, look, we need some more data here to make sure that this is a safe device to implant. The majority of these events were actually effusions. So a little bit about PROTECT AF, because the devil's always in the details. 707 patients randomized in a 2-to-1 fashion, meaning that for every 3 patients, 2 patients were receiving the device, the other was going to stay on Coumadin. And the primary endpoint was that of all-cause stroke, cardiovascular unexplained death, or systemic embolization. And you can see with the primary endpoint, if you focus where my mouse is, this is 3% in the intervention group and 4.9% achieving non-inferiority. The area that gave cardiologists some pause here is this ischemic stroke. Now, this is not all-cause stroke, but this is ischemic stroke. And the observed rates were a little bit higher in the intervention group. But I can tell you, out of these 15 patients, one of these patients actually was randomized, did not receive the device, and had a stroke. so that they had not received the intervention yet, but were randomized before. And there were 5 patients with air emboli during this. So if you look at the overall numbers, you can see that will actually bring your numbers down closer to about equivalence. Ultimately, in the hemorrhagic group, there was a straight win out here for the Watchman. There was 1 patient that had a hemorrhagic stroke that actually occurred days after the device implantation while the patient was therapeutic on warfarin with an INR between 2 to 3. And then in the control group, you see hemorrhagic stroke occurring in 6 patients. Now, these are the devastating strokes for cardiologists, neurologists, and of course, patients and their families. All of these patients here had therapeutic INRs. They were not above 3. They were between 2 to 3. So the other issue was the safety endpoint here. And as I said before, it was really in the pericardial effusions that were occurring. And that actually rate dropped off between the first half of PROTECT AF. And the reason why that occurred was that this sheath here is a little bit blunt on edge, and the appendage is a thin-walled 0.5 to 1 millimeter structure that can be flimsy. And when you go in with this blunt edge, you can cause effusion. Placing a pigtail here as a bumper was actually an added to the procedure that led to improved safety. So ultimately what we gained is that it's non-inferior to that of warfarin. And you can see from the meta-analysis here, same thing, heavily favors warfarin, the Watchman in the hemorrhagic stroke area. As far as there was a signal towards all-cause mortality here, probably driven by bleeding. And then there's the ischemic area that still hangs out here that gave us some pause. I explained in the first study with PROTECT AF. In PREVAIL, the Coumadin arm was actually extremely low in the PREVAIL trial. This was the second randomized trial. If you look at the contemporary trials comparing NOACs and DOACs to Coumadin, in the Coumadin arm, your rates are 1.7, 1.6, and 2.2. There was an unexplained extremely low rate here. And so, I would argue that you could kind of push these lines if you look through the details and argue that there is some equivalence here with Watchman. So with the decline of procedural complications, there was an increase in success. And ultimately, in 2015, there was FDA approval. So as far as the FDA, I think CMS got it a little bit better with this statement saying that it's eligible for patients that are suitable for short-term warfarin but deemed unable to take long-term oral anticoagulation, and those patients that have a TRAS-VAS score of 3 and greater. And it's not just for patients that are having bleeding. You have to think about your elderly patients that are poorly compliant, those that have a risk of falls, severe renal disease, all indications. Okay, so ultimately out of all this, what I'd like for people to start thinking is that instead of when those patients come in with GI bleeds into the hospital and you're getting the consult for, hey, when can we restart anticoagulation? I think the question should start to shift towards, is this patient a potential Watchman candidate? And you will save a lot of time, money, and aggravation for patients and their families. So as far as a little bit of the throughput, I'm running short on time, but ultimately you'll see the patient in the office. You'll explain to them that they're going to have a TEE to initially, prior to the procedure, to look at anatomy and to help size the device. And then during the day of the implantation, they'll need another TEE to help guide therapy. And then prior to discontinue of anticoagulation, about 45 days out or so, they're going to need another TEE to prove that there's no clot on the device and there is not greater than a 5 millimeter leak. This was the guideline therapy based off of the trials. I'll tell you now, we use this with NOACs and DOACs, and the Aspen 325 has actually been cut down to 81 milligrams to make it easier for patients. Okay, be respectful of the variable anatomy of the left atrial appendage. On a side note, there is a new device by Watchman called the Flex that makes navigating these anatomies a little bit easier. That's a story for another day. But it just shows the role of your echo sonographer here in terms of identifying all lobes and really identifying the anatomy. So back to our case here, we're getting 4 different angles by TEE, a 0, 45, 90, and 135. As far as usually it's the 135 that's going to be your implanting view. It's also conveniently the view with the widest os to help you size your device. Trying to click forward here. I can no longer click. Oh, there we go. And there's also correlating images on fluoroscopy, and we actually help size the device by calibrating the sheath to the fluoroscopic views, and they do correlate. An RAO cranial will correlate with our 45 degree, and an RAO caudal will correlate to the 135. Ultimately, there's 5 different sizes with the Watchman 2.5. Obviously, the flex is a story for another day, but just a short, brief portion of the procedure. We're going after the fossa ovalis for our transseptal puncture. And if I can get these to play here, what you're seeing here is the SVC and the IVC. This is a 90-degree bicaval view with your intra-atrial septum, and you see tenting here in an inferior position. We want to get to that superior and anterior structure, which is the left atrial appendage. Okay, and once we are tenting in this bicaval view, we can X-plane. And if I can play here, you can actually catch a piece of the aorta here on the left where my mouse is. So you know that aorta is an anterior structure, and you're actually sitting posterior here. So this is our patient. She received a 33-millimeter device based off of her pre-sizing TEE. You can see the device actually being delivered here, okay? And it actually will pop into place. You're unsheathing device when you're deep in the appendage, never pushing forward. And you'll see the device being released. So we look at TEE to let us know whether or not we can finally release the device. We always have a chance to recapture if need be. Okay, and this was our patient here with the device sitting nicely. These are, again, the anticoagulation strategy. And the reason is to allow for endothelialization. This is a canine model here at 45 days. You see nice endothelialization of the appendage, a time when a patient can safely come off their anticoagulation. So ultimately, in summary, left atrial closure with a Watchman device. It's a safe procedure that was proven to be non-inferior to warfarin therapy. It should be considered for patients that are suitable for short-term anticoagulation but have contraindications to long-term therapy. Thank you very much.
Thank you, David. This was excellent presentation and a beautiful demonstration of the Watchman procedure. Moving on to our next speaker is Dr. Brian Cluck. Dr. Cluck is Assistant Professor of Medicine at Lehigh Valley Health Network. Brian has been performing PFO and ASD closure procedures for the last many years and has been a leader and investigator in many PFO trials. He will discuss with us stroke in a young patient without risk factors, the role of a PFO closure. Brian.
Thanks very much. See if I can get my slides to play. I'm not quite successful. If you go to the next slide for me, please. Thanks. So this is me. Next slide, please. No disclosures. I am an investigator in the GORE Continued Access Study and the GORE Relief Migraine Trial. Next slide. So this is a 37-year-old right male. Click. Next slide. Admitted to the hospital, right MCA stroke. Returns from the Outer Banks by car within the last 2 weeks. Next. Straining at stool when he noticed a weakness of his left hand. Next. He tried to stand. His family found him down. Hospital stroke alert was called. You can see the arrow sign. Next slide. 24 hours later, he had improved. He had mild left hemi neglect, mild left sensory loss, no ataxia. His NIH stroke scale was 3. And in 48 hours, it had improved to 0. Next slide. So the TE was performed at the outside hospital. It was actually a network campus. The PFO showed a large bubble flow, atrial septal aneurysm, no left atrial enlargement, sinus rhythm with no evidence of thrombus or smoke in the left atrium or left atrial appendage. So the question is, was this a PFO mediated stroke or occult AF? And I think Dr. Saver sort of helped us a little bit in terms of statistics. The patent foramen ovale, just to know what a foramen ovale is for frontline workers, an intraatrial septal passage. It's bound by the primum inferiorly, which is thin, the secundum superiorly. It's open during fetal life. It's usually closed by 3 months of fetal life. It's present in a quarter of the population. Its mean size is about 5 millimeters. It ranges widely. But very importantly, cardiac echo studies, no matter which, don't accurately measure the physical hole. The size is inferred by bubble study or Doppler flow. Physiologically, I know everybody hates physiology, but the returning of placental blood from the inferior vena cava goes across the PFO because there's high vascular resistance in the branch, main, pulmonary arteries in the right ventricle. And so there's a relatively low resistance across the septum primum, which allows flow to go to the left side. On birth, lungs expand, reduced resistance at the branch main pulmonary arteries, and back in the RV, which then allows relatively high resistance on the left side and flow to go in the normal fashion. Paradoxical embolus, you can see bubbles in this slide going across the septum by the septum primum being separated, and you can also see the possibility of a clot going in that direction. Circumstantial evidence, as Jeff mentioned, long suspected but uncertain, twice as prevalent in cryptogenic stroke patients than in the general population. Therapeutic options were antithrombotics, percutaneous closure, or surgical closure. A TCD with bubbles is very, very sensitive test for this. And in this particular patient, there were lots of hits on this patient's TCD. His loop recorder, which was placed at the outside hospital, no atrial fibrillation, no SVT, no pauses or heart block. His rope score, or a rope score, let me just skip this because Jeff talked about it, and go on to this gentleman's rope score, which was a 9, suggesting there's an 88% chance the stroke was PFO attributable, and the stroke risk at 2 years was about 2% at 2 years. Our combined cardiology neuro conference took into consideration the fact that he worked in a maintenance department with heavy lifting, and we just chose to close the PFO. The access was accomplished in careful, meticulous ultrasound guidance in the right common and left common femoral veins. AccuNav ICE was utilized. Amplatzer PFO Occluder was chosen. The case was uncomplicated, and the patient was discharged the following day on dual antiplatelet therapy. These devices, based on recent literature, have been approved, but they're approved with specific verbiage that you can see here, as determined by a neurologist and cardiologist following an evaluation to exclude known causes of stroke. This is the Amplatzer device, and similar verbiage in the Gore Cardioform, which was already approved for ASD, involved the collaboration between neurology and cardiology to decide on which patients would benefit from this. So this is our image. This is an intracardiac image for orientation. The catheter is in the on the right side, the right atrium. The septum primum is thin and jump rope-like. The septum secundum is thicker and more superior. And you can, I think, if you look, see a little bit of Doppler flow that crosses at the juncture of those two septa. This is agitated saline, which clearly crosses quite well across the septum. One trick is with the intracardiac echo, you can kind of measure your septum from the center of the catheter crossing to choose your device. This is a picture of the delivery sheath, which goes in from the groin. Our particular, we favor going in from the right groin for delivery. And then on the right, you see the picture of a wire crossing up into the left upper pulmonary vein, and you can see the loop recorder in the field. This is, if you look carefully at the septum, you can see a device crossing the septum, and the Amplatzer device left disc is in the distal left atrium. Now the disc is snugged up against the intraatrial septum. Now you can see the right disc is being deployed up closest to the top of the screen, and you can see the same thing on the fluoro image down below. This is so-called Minnesota wiggle. You can push forward and pull back with the cable on the Amplatzer device to allow for certainty that your device is in good position and is not likely to embolize. You can see the rims that are captured and visible, and you can see on the Doppler on the right the same thing. And now you can see, if I can make this play, and I can, you can see the device being, the cable being unscrewed, and you can see now the device is left behind. Intraprocedural complications are dark, but I can say that as I've lived through most every one of these, the blue will tell you that with careful technique and imaging, you can avoid most, if not all, of these complications. Chest pain, nickel allergy, extremely rare, But at the very bottom of the screen, atrial fibrillation, which is really the issue, and there it is present with both devices, perhaps a little less so with the Amplatzer, but it is something that you'll run into. This is one of the dreaded complications of device embolization, which, as any good interventionist will tell you, is not my case. And you can see on the right, there's a snare that's pulled the device out. In these cases, when this happens, if you find this, you can and should, of course, remove it, and you can put a larger size or more appropriately sized device in. Long-term endocarditis, I favor antibiotic prophylaxis for a year, but at least 6 months. A large residual shunt by echo might require further investigation. Thrombus formation is not really very common, and device erosion in PFO devices is quite rare. In this case, just for sweetening the case, 2 weeks later, this patient's wife called with a heart racing and palpitations lasting 20 minutes, which was a new feeling for him. This happened every hour or so over the weekend. Nurse practitioner office visit demonstrated sinus rhythm, and the symptoms hadn't recurred. So CardioNet was placed, and 5 days later, actually, this patient's loop recorder told us that the patient had a heart rate of that was episodic at 150 to 200, AFib, and the patient reported return of palpitations. This was a little bit of a cluster, you know what. There were some Lovenox to warfarin prior to his discharge from the hospital. Antiplatelet therapy was then chosen. Rate control ultimately with Toprol XL for 25 and Diltiazem 120, and that was that. Early on, the trials did not support us. This was the winter of our discontent, to quote Shakespeare. The neurologist recommended against this. The ACC/AHA recommended against it on a routine basis. And then in the positive trials in September of 2017, all were then in favor. And a fourth trial, Defense PFO, which showed even in the elderly population, there was some benefit, also published in JACC in 2018. As was mentioned, the nomenclature has changed into PFO-associated stroke. And I would make a plug for everybody working on a neurocardiology clinic. We've learned with our neurologists and cardiologists to work together, and we've really expanded the overlap between these two specialties. And I thank you.
Thank you, Brian. That was an excellent presentation. So now is the time for panel discussion. We request all of you to submit your questions in the QA box. We already have a few questions here. So Jeff, David, Brian, can you guys unmute yourself? And yeah, that's great.
Can you hear me? I cannot get my camera on, but I can.
That's right. I don't see your picture, and same is for Shelley, and here it is. David is right there. So so there are a lot of questions. That's great. Let's get started with a few of them. Shelley, can you hear me?
Yes, I can.
Okay. I mean, somehow I can't see your picture, by the way. So there it is. Thank you. First of all, Jeff, that was excellent and very comprehensive overview of stroke, you know, the workup and everything. And tying this all together, so we have a younger patient who has cryptogenic stroke and has a PFO is relatively straightforward, and an older patient, you know, 80 years old, has a cryptogenic stroke, you know, most likely is paroxysmal AFib and stuff like that. It's relatively clear. But how about a patient who is 50 to 60 years old, has a PFO and has a cryptogenic stroke? Number one, you know, what is your algorithm for workup in that patient, and how long would you do cardiac monitoring before you pull the trigger to close a PFO?
Sure. Well, you know, first I'll note that the 60-year-old cut point is, we know, artificial coming out of the trials. FDA label doesn't hold a hard line there. The AAN guidelines do, but a 61-year-old is not going to be all that different from a 59-year-old. But as you get out of the young middle-aged people to the older middle-aged people in the 50 to 60 range, you do need to worry about AFib as a competing cause. And then if you find low burden AF and a PFO, it's hard to say which was the cause. They're both low grade risks. They're not high grade risk. And I am concerned that too often neurologists have been transfixed by the idea if they just keep looking for AFib, that they'll find it eventually, and they keep putting off treating the PFO that's in front of them with monitoring interminable for 3 years before they decide it's the PFO. So I think that if it depends on the nature of the PFO, if it's a large shunt, ASA, present high-risk PFO, then I think with just right after the inpatient telemetry, if that's all you found, you don't need to go looking for AFib, you can go ahead and close. On the other hand, if there's atrial cardiopathy, left atrial enlargement, you're worried about the atrium, and the PFO is of lower medium structural risk, then I think you should hold off to at least 2 or 4 weeks of monitoring and see what you see before you go to closure. So you have to take each case individually.
Sure, no, that's great. Brian, what do you think from a cardiac workup standpoint, and you've been dealing with these patients for a long time, so what's your comment on a patient in that age range?
I think that's exactly, Jeff hit the nail on the head. I think that you can monitor indefinitely, and the industry standard for looking monitor-wise, I would say, is probably 30 days. If you have somebody that's well over the age suggestion in the FDA approval, I think you can go as far as 6 months. But I'll tell you, if you get beyond 6 months and you find atrial fibrillation, I think that may have nothing to do whatsoever with the patient's prior stroke or their likelihood of having a PFO associated stroke. I think you found something else in an older person. Atrial fibrillation is increasing in frequency as the age goes on. And I think if you look at that intra-atrial septum and you find a large bubble flow, great atrial septal aneurysm, a large eustachian ridge, spontaneous flow, I think not walking away from that after a fair amount of monitoring is a mistake.
Got it. So, no, that's a great comment. So a question on a similar lines on PFO closures. I learned PFO closures 10, 15 years ago when I was a fellow, and obviously there was not much data back then. And then all of a sudden we have like 3 trials published within a few days, a few weeks, that here you go. Why there was so much lag, from the procedure to data? Any comments on that, Jeff?
Well, it is the case that, medical therapy for PFO is not all that bad. The event rate on antiplatelet therapy is maybe 1% to 2% per year. And so PFO closure reduces the events by 3/4. So it makes a big relative difference, but the absolute reduction is small because the medical therapy works pretty well. And so that means you need a large sample size to get patients. And then we had the problems of people thought they knew the right answer while we were doing the trials. For the first 8 years, everyone said, oh, I have to close the patient, I'm not going to randomize them. Then the initial results came in that people interpreted as neutral, even though they were slightly favorable. And everyone said, oh, I'm not going to close, I have to do medical therapy. I'm not going to randomize because they shouldn't. So we had trouble getting patients into the trial, but eventually everything was always consistent with what we found, that there is a modest but important benefit from closure for the right patient.
Yeah, if I may make a comment, Mohammed, I think we're probably all in agreement that closure is not for a patient with a questionable neurologic event who has a small incidentally found PFO. We're really talking about a clear-cut event. You need to get your neurologist on board to say that this was an embolic stroke. And you want to look at patients who have a large shunt with an atrial septal aneurysm and a large PFO. If you focus in on those patients, I think you'll be doing some good. There's a great question here from the audience, from Dr. Mehta, that I would get all the time. What about an incidentally noted PFO, an atrial septal aneurysm on a routine echo? any proactive intervention to take, aspirin, anticoagulants, closure, or nothing. This is a patient without a thromboembolic event.
You know, I think there's data from way back when that says if you look at the patients in the general population, PFO positive and PFO negative, their stroke risk is about the same. So I think you treat that patient for their overall condition and would not treat the PFO.
Yeah, I think there's some simple things you can do. You know, certainly, if they're a scuba diver, you might think about closing, and if it's a really structurally bad, it's expensive grade 5 huge shunt and an atrial septal aneurysm, a big juicy PFO, at the least you can tell the patient if they go on airplane flights or long car trips, stop every 2 hours, walk the aisle, hydrate, maybe take some prophylaxis just before the flight as a simple precaution. That the risk overall is very low in primary prevention incrementally, but for the really bad ones, there's some simple steps that are risk-free and worth doing.
And I think, you know, you bring up a really good point, and that's that it sort of depends what the patient did. A number of years ago in the data poor era, I had a patient that had a small stroke, very young person in their 20s, and came and asked for advice. And I went along the medical therapy lines and I said, but, you know, I know young people, you know, avoid things like scuba diving. And if you're going to lift weights for reps, not for, and he said, you know, doc, I'm the president of the Pennsylvania Powerlifters Association. So I closed him. Okay. So, you know, you have to know the patient.
Well, so there's a well, that's a great comment, Brian and Jeff. So there's a question from one of my mentors and a person who has done PFO closures pretty early on and is very experienced in this field. So the question is for Brian and maybe Shelley can comment. So risk of erosion, are concerned for risk of erosion in PFO closures. Any comments, Brian, on that?
Erosion or difficulties with the device for PFO is a very rare event. Fundamentally, the Amplatzer device, the ASD device, works differently than the Amplatzer PFO device, which has not as much force against the septum, against the pericardium, against the aorta. So I think that's a very rare event. I think you need to take it a little bit more seriously in ASD. Those devices tend to be bigger and they tend to be anchored by the connecting bridge rather than the discs. But I think the risk is, I would not shy away from closure because of erosion in either device. Right.
So the in a nutshell, for PFO closure, I mean, the risk of erosion is very
infinitesimal,
almost unheard of, and that has been our experience also, you know, doing this for the last 20 years, as Dan and Shelley know. We haven't seen any erosion from PFO closures for last 2 decades. You know, asking when I asked a question to David Goldberg, I mean, David, first of all, there was an amazing talk on this topic and very timely, obviously. So, you know, when a patient gets senior in life, you know, Chad's VAS score keeps escalating. So, you know, 70 years old versus 80 and then 90 years old. And those are the patients who are at risk for falls and dizziness and, you know, the blood pressure and hypotension, all kinds of issues. And so, but at the same time, this is an invasive procedure. How do you manage those patients who are really like 90s? Do you offer these procedures to those patients? The fact it's a venous procedure, any comment on that?
Well, it's interesting. I just had a patient the other day, 87 years old and a Jehovah's Witness, and had some issues with spinal stenosis and had, you know, was really afraid of falling and had a couple falls, nothing bad that required hospitalization, but he was newly diagnosed with atrial fibrillation over the past couple months or so. And it just started on Eliquis. And I honestly, I'm bringing up this story because I think it's a case-by-case basis. I mean, he's 87 years old. We initially offered the procedure to him because I thought it was reasonable in this case. He had actually never bled, but you know, you could understand the potential to bleed in a Jehovah's Witness. And also the concern for him falling. So we offered the procedure. We spent a lot of time talking, having long discussions about it. He met with another physician, and I think it's the importance of shared decision making. Ultimately, he decided that he was going to continue with Eliquis for this time. And, he asked me point blank, he said, "Do you think I absolutely need this?" And, in all honesty, I never want to convince anybody into doing a procedure like this. And so, but we said that the option is always on the table if you'd like to come back. And I think his decision was a very reasonable one. Now, there are slam dunk, cases, but a lot of times I think it just speaks to the importance of shared decision making, talking to the primary care physician, seeing what their concerns are, as well as the patients and their families.
Sure. So there's no age limit, in other words, that just like for many other transcatheter procedures, we offer them without any age limit. And I agree with you, the shared decision making and having a discussion with the patient. So, but I think you nicely demonstrated in your talk that this is like a venous procedure. We have really evolved into, making it a very safe procedure. So, age in itself is not a contraindication for this procedure.
Yeah, thanks very much. If I may address an open question from the audience, question I would get all the time: what about a sizable PFO in a patient with severe unrelenting migraines, unresponsive to standard medical treatment? What do you think, Jeff?
A good patient to refer to the randomized trials. I think the two trials that have been done have been suggestive. Both have point estimates favoring the benefit of treatment, but they were not definitive. And there's good pathophysiologic reason to think that both the effects of serotonin clearance in the lungs and platelets affecting migraine pathophysiology and headaches set off by tiny emboli in the brain, that it could be beneficial. But it is a major intervention for a transient condition. So we need definitive data, and the trials are underway.
No question. Migraineurs, which is most of my family, will do anything to make their migraine go away. So you can't lead them. This has to be something that's data driven.
So any final comments before we close, Shelley?
Yeah, I'd like to ask a question about screening patients who you suspect may have a PFO. And we talked about transthoracic versus transesophageal echocardiography. And I addressed this to Brian or Jeff. Could you talk about the sensitivity of these two techniques in detecting a PFO? And I've always thought of the transthoracic as reasonable with the bubble study, and the TEE more for structural details about the PFO and atrial septal aneurysm and associated defects. Any comments on that, guys?
Well, I think if you want sensitivity, I think the thing is a TCT with bubbles. It is a very, very sensitive test. It doesn't tell you structure, and it doesn't tell you whether it's a PFO or an atrial pulmonary AVM. But honestly, if you're looking for something that's pretty straightforward to do, and if you want to know if there's a right to left shunt, that's a very good tool.
And I'll add that, I do think that both TE and transcranial Doppler are better than transthoracic echo. Transthoracic echo is pretty good for the medium and large, but it'll miss the smaller ones. The transesophageal echo has the advantage not only of doing better look at the PFO than the transthoracic, but it also looks at the aortic arch. We're always worried about aortic arch atherosclerosis as a competing cause of stroke in these patients. It also looks at the atrial appendage for tiny thrombi that might suggest intermittent AFib. So it is a preferred technique. Transthoracic is good as an initial screen, and transesophageal is much better in patients who can't Valsalva or refuse TE. But the best single test, I think, is the TE.
So I have to tell you,
when you refer patients, I'm sorry, when you refer patients for your transthoracic echo, make sure you indicate the reasons that you're ordering it is to rule out a PFO, and make sure people get a bubble study with Valsalva to look for crossover as an initial screen. The TEE is going to tell you much more about anatomic detail, which is important to the physician who's going to perform the procedure.
One very important point for the generalist is if you strongly believe that this is a PFO-associated stroke, there's about a 10% false negative rate for TEE, and just don't be thrown off the scent.
Yeah, no, these are great comments. So one question on same line. So if a patient has a PFO and has hypercoagulable state and has a stroke, what do you do? Do you close and continue anticoagulation, or you think patient is bound to anticoagulation rest of the life based on what kind of hypercoagulable state is? So any comments from Jeff and Brian?
Well, you know, we did see in the RESPECT trial an increased frequency of recurrent DVT and PE in patients who had a history of DVT and went to closure because the anticoagulation was stopped. So these days, there's low-grade American chest physician recommendations for near lifelong anticoagulation after an unprovoked DVT and especially after a hypercoagulable state. So I think they need to be anticoagulated, but sometimes they will also benefit from closure on top of the anticoagulation if they're going to be having multiple surgical procedures where they're going to be going to anticoagulation holidays. Then structural barrier protection will also be helpful. So sometimes it's both and, not either or.
I'd have to say also that hypercoagulable state is very different depending on what particular element you're talking about. Antiphospholipid antibody is a lot different than protein C or protein S. I think that you have to take, again, this is one of the things that we argue about at our neurocardiology clinic, because it's pretty widespread as to, you know, the hypercoagulable state itself.
Mm-hmm. Yeah, no, that's great comment. It depends. Obviously, the devil is in the details, but I like what Jeff said is that sometimes you have patients with hypercoagulable state, but you still think the closure is better, as you know, at some point they're going to come off of anticoagulation, and so it's not like because they're going to be on anticoagulation that we shouldn't close a PFO.
This is the trial I want Jeff and I to do, which is going to be called the belt and suspenders trial.
Exactly.
Well, it looks like we're getting almost to a completion. So, Shelley, any comments, or I'm allowed to close the?
Yeah, I just want to thank the speakers, my co-moderator, Dr. Raza. I'd encourage everyone to visit the CVI website to learn about our programs. This program will be posted on the website, so if people want to review the slides or data afterwards, that's a good resource. So thank you, Mohammed.
Thank you, everyone. So we would like to thank all our sponsors again and exhibitors, including our leader-level exhibitors, Abbott Labs and Pfizer Bristol Myers. We look forward to seeing all of you at our upcoming programs. As Shelley mentioned earlier, our second stroke webinar, which is prevention and management of CVA. So if you look at the concept of this is the cardioembolic stroke and prevention, and the next webinar is going to be on vascular disease and prevention and management. Will be led by Dan McCormick, Rich Kovach, and Bill Gray. And also, please look out for our 27th cardiology update. The keynote speakers are Dr. Brunwald and Dr. Milton Packer. And the program will take place on October 25th, 6th, and 28th. Thank you all. And thanks to Marlo and Mark Hartnett for making this happen.
Thank you.
Good night, everyone.
Thank you. Good night.